Welcome, everybody, to Do More Better. This is going to be the first episode in a series of episodes on ADHD.
Yep.
So one of the things we've been talking about is just, in our first episodes, and as we get better doing this, that we're kind of all over the place sometimes.
Yeah.
And so we're going to try to make it a little bit more specific and give more digestible pieces to people.
Right, we're kind of horizontal thinkers sometimes, and so we think about this, and that reminded me of that, and then I'll go over here, and then I should probably get back to what we're talking about. So we're going to try a little bit, be a little more targeted.
And I think you and I both have I would call it a good ability to just feed off the other one. So if you bring up something that I wasn't really thinking about, we just end up completely following that, white rabbit down the hole. Yeah. ADHD is, everybody knows it. It's, again, kind of one of those ideas that,
if you haven't heard of it, where have you been?
Right. You've been under a rock if you haven't really. And if you're not interested in ADHD, go back and listen to the masturbation episode.
Yeah, or we'll do another one on masturbation, I'm sure. Just skip to that one.
Skip to that one.
Yeah, skip the next 3 or 4. Yeah.
So we broke it up into pieces. The first piece was just talking about the diagnostics of it all and identifying it, coming up, evaluating the criteria and those kinds of things. Just because we're guys, oftentimes we get referred a lot of young boys. It's more prevalent in boys than girls. And so I do a little bit more assessment than you do, but I would just say assessment in psychology, I would say ADHD makes up a big chunk of that anyway.
That'd probably be the number one thing you're going to assess for.
Right.
That and anxiety or depression would be pretty close number 2s. But yeah, particularly like early school age, like 3rd grade-ish.
Yeah. I always know that come October, I'm going to be slammed with evaluations for ADHD. If somebody's had their first,
it's always October.
It's October. People are starting to go inside with each other more. The honeymoon phase has worn off in school.
Grades are coming out.
Grades are coming out. You've had your first parent-teacher conference, and these young kids are, most likely not doing so hot, and that's why a parent comes in. Yeah,
I'd also like to see, does that vary based upon when the standardized tests are coming out too?
Does what vary?
Like say you're an outpatient behavioral health clinic or you're a school psychologist, actually would be really important, is the referrals for ADHD-ish referrals, depending on when you're doing your state testing. Mm-hmm. Because, we can get into that.
I got you. You mean like the academic state testing. And so,
So if Nebraska does it at this time or like Minnesota does it at that time or, you might see more referrals like pretty close to when that assessment's coming up, that standardized assessment. So, yeah.
Let's talk a little bit about what you're expecting to see, what symptoms are related to ADHD.
Sure. Actually, I meant to talk about this off camera, but the age stuff changed, right? So DSM, probably refer to the previous episodes in the diagnostic manual, used to be had to kind of show up before like 6 or 7. Now I think
it was
it's
age
10.
5 to 7 is what they said.
Yeah, now it's 10.
Oh, is it? I didn't even know that was changed.
I think it's 10 now. Actually, just recently looked at that, which is probably says something about the DSM. That I'm not gonna get into it.
No. Hey, go for it first.
It might be a little more subjective. It seems like a very scientific thing, and it seems like like when you have strep throat, you have these symptoms. When you have ADHD, you have these symptoms. But the DSM-4 to the DSM-5, there's a difference in the age. I'm pretty sure there is. Maybe I should check that out.
Well, no, but I'm glad you said something about like strep, because if you go to your doctor and you say, I think my kid's got strep here, they're going to go, cool, swab you in the throat, go back, and they're going to come and tell you pretty definitively you've got strep or not.
Right.
There is nothing like that for ADHD. There is no blood test. There is no swab. I can't go in the back, spin a centrifuge and come back and go, oh, you're looking at ADHD. That's what it is.
Right, exactly. Although, so we have some fairly decent research that says it's related to, brain development.
Right. We'll get into that, yeah.
Yeah, it's related to neurotransmitters and imbalances and things like that. There's no brain tests and there's no neurotransmitter tests. It's all behavioral.
I think there will be someday, by the way.
I think there will be too. And I've seen some clinicians use EEGs. I don't think it's very accurate.
I hate it when they do it right now. I think they're kind of being way too cavalier with it. But that's the kind of, in 20 years from now, I would imagine we could, hook you up to a computer and the computer goes, oh yeah, there's that frontal lobe.
It sounds great. Yeah, I'd love to see that. Yeah. But I've actually done way back where you met with kids. I'm like, well, this is fairly obviously ADHD, who had seen an EEG diagnostician beforehand who said no. But to me, all of the symptoms were there. And so let's get into symptom stuff.
Remind me when we get there, talking about symptoms as far as like the difficulty in every assessment, whether it's ADHD or anything in childhood, is that you're really dealing with this black box anyway. Like you're trying to assess something. And even if you get a symptom that comes out looking one way, it could technically be something else anyhow. I think of like a real prominent idea I had in my head. Like I had a case one time where all the symptoms looked like ADHD. I ended up diagnosing the kid with depression after a little more interviewing and some things going on. So
that makes sense. Depression would affect your working memory, which is a primary ADHD thing we look for. Yeah. Right. So you probably had a different plan here, but
we're already way off the plan.
I would have renamed ADHD.
Yeah.
I would have renamed it executive functioning disorder. But as we see with the continued use of ADD, which we're going to get into, it messes people up when you change name. I don't really think ADHD, it's attention deficit hyperactivity disorder. And then so we've got subtypes. And so we've got combined, we've got primarily hyperactive, primarily inattentive. And technically, if you get into the DSM, there is an unspecified, so you can say this kid's got ADHD, but we don't know what type. And so it can be any one of those types. But really what it boils down to is an executive functioning difficulties.
So the symptoms, typically you're looking for hyperactivity, inattention, poor impulse control, and then deficits in executive functioning. So planning, organizing, decision-making. There's, like you mentioned ADD before, there is no more ADD. The DSM updated itself, and now there's these components of ADHD. There's ADHD hyperactive, ADHD inattentive, ADHD combined, and the not otherwise specified.
Right. I would just to stick with that topic for a second, I think it used to be once a month that I had a parent come in and say, well, no, my kid has ADD. Not ADHD.
Right.
Now it seems to be once every 6 months. So it seems like the idea is getting out. There is no more ADD. There is no attention deficit.
It's a moving target and hard for the public.
It's gotta be hard,
these poor parents are told one thing 5 years ago, and then they come back and it's like, oh, by the way, that's totally different now.
Right.
And so, like, strep hasn't changed for you know what I mean?
Right? Yeah. And so if your child has been diagnosed with ADD, not anymore. They technically have attention deficit hyperactivity disorder, predominantly inattentive type.
And so some of that is trying to get better at diagnosing the problem. Some of that is, changes in PC culture and in the way we phrase things as far as like diagnosis. And some of it is, it's, again, we've said it before, but we're a young field and the target is moving. It's changing all the time.
Yeah, right. And I think I prefer the getting rid of the ADD, and to be honest, is because somebody who's just inattentive, sometimes they're hyperactive, so it's not like they never are too, the one thing that, as I've been thinking, we're sitting here talking, is like, you rarely ever see a kid, like you brought up, who is hyperactive, but not also inattentive.
Right.
And so
or impulsive or something.
Yeah. And there is a predominantly hyperactive. I have never diagnosed it.
I've done it for a couple, but I mean, it was based more off of like, diagnostic numbers that I got back. But one of the things is basically, even though that ADD is gone, and even though there's these subtypes, what families ought to know is it gets treated the same. I mean, the interventions, the medications, basically it's those subtypes and the way they categorize them are meant for communication between us as providers. Right. So what symptoms I saw and what I'm looking at. But basically, if you have ADHD hyperactive component or ADHD inattentive type, you're talking to the doctor about the same medications, most likely.
Right. Exactly. And when it comes to school stuff, which school will be an important part when we're talking about ADHD, it really doesn't change anything either there. So the one thing that gets confusing, I think, for parents is that a special education classification ADHD is not one of them.
Right. Schools can't diagnose it. Yeah,
schools can't diagnose it. So you will not get in special ed for having ADHD. You would get in special ed for having an other health impairment. So OHI is what you would hear. So if you have ADHD, then you can get special education.
You get a letter from your doctor. You send it in.
It's a pretty easy thing. And so if it's something that's already there, you just basically ask your doctor to write the letter.
And just because you get a letter from your doctor saying your kid has ADHD does not mean you get qualified for supports at school.
It does not,
or an IEP, which is an individualized education plan. But I'm sure we'll go more into IEPs at some point.
Yeah,
but,
we probably should do an episode on IEPs at some point.
The hard part about that is I think education is trying to do justice to kids by getting them support that doesn't necessarily look medical. It looks educational. And then, physicians are trying to do the exact same thing, getting kids help that is medical that may not necessarily be educational, and it ends up being a pretty, I'd say more often than not as a provider, it gets more frustrating than anything because you got, two different jargons, two different conversations, and parents left trying to learn both of them.
Right. Back to the standardized testing, I have seen it happen where parents are very concerned about getting their kid on the right medication before they take their state testing. And I've talked to my doctors I work with, and they say, no, that doesn't matter. They're like, that testing's for the school, not for your kid. You know, we'll figure out the medication when we figure it out.
Yeah.
But I think we should stick with executive functioning a little bit because that's probably where, like the major, so that might be something like literally anybody who hasn't been living under a rock for the past 20 years knows what ADHD is, but executive functioning, I would say, is not something that's talked about.
And that's
often.
probably the most, you get this all the time. I think I see it especially with dads where it's like, hey, is ADHD a real thing? Like, is this a real thing? And I would say executive functioning and some of the studies on like brain development is where the most consistent, like, oh, okay, yeah, something is going on here related to that brain and that executive functioning skills. Right. There's research backing that up. It's almost like a 33% delay for some of those kids.
Right. Yeah. I wish, and if HIPAA were to allow it, that I could take some videos of my kids who legitimately have ADHD and show other parents.
Yeah.
Because when you see it, it's a lot different. But I mean, way overdiagnosed and way over referred for, I think my kid has ADHD. And I would say I like to be, and I bet you're the same. I like to be the one provider who's more likely to find not ADHD, which is the way it should be.
I try to be real conservative with that diagnosis just because, I feel like when I go into an assessment, any assessment, but the assessment should be a tool as part of my clinical decision making. But, I want those numbers to really, really convince me that I'm supposed to be going down that road. I don't...
So stick with that. Like, what do you usually do?
As far as the testing?
Yeah. Like as far as
a typical ADHD assessment is going to be behavior rating scales. So you take... typically, I give a global one. So a behavior rating scale that asks about everything. It'll ask about depression, anxiety, school behavior, oppositionality, hyperactivity, inattention, emotionality, internal, external. And then I'll pair that with a specific ADHD evaluation or a measure rating scale. Yeah.
Right.
So specifically asking about hyperactivity, inattention, and the associated symptoms of ADHD. Then I'll give another behavior rating scale that looks at skills of executive functioning. So I think of my
brief-ish.
Brief 2 is typically what I give. So I think about my assessment as the first step with that global measure is I'm asking the parents and the teachers, if I let you call it anything you want, what would you call it? Then I move further in on my evaluation. I say, okay, when I get to the ADHD behavior rating scale, I think if I ask you to call it ADHD, are you willing to call it ADHD? Then when I get to the third one for those skills of executive functioning, I'm asking, okay, if you called it ADHD, how? Where does it show up, and what does it look like on their executive functioning skills?
So, like, maybe we should give a little background and training. So, all the things that you just brought up are things that any psychologist should know how to do. So, we get training. So, basically, we should probably talk a little bit about testing and how that's set up.
Yeah, go for it.
So, basically, we have these rating scales, and so if you've ever been asked to fill out one of these, then there's been
not a symptom check.
No,
very different.
No,
the Vanderbilt, which is probably the most common that your physician, your child's pediatrician is going to give you, that is a symptom checklist. That is not what Drew is talking about.
So medical doctors tend to look at things a little bit different than psychologists do. And when it comes to test design and measurement, I think what Wes brought up was a really good point is he gives a global assessment. And so what looks like ADHD sometimes is actually depression. What looks like ADHD is actually anxiety sometimes.
And it would make total sense that if you had a kid who's inattentive at school and the issue is depression, that if they're too busy, like gestating on these depressive thoughts, they're gonna look inattentive.
They can't. It's really hard to pay attention whenever you're having some of the thoughts that they're having, or if they're very, very anxious, it's going to look inattentive as well. And so that global measure. So basically, the way this is designed is, if you're filling it out for your kid or if you're filling it out for yourself, they've had thousands and thousands of parents fill out the same scale, and we can come up with what is normal, but what is about normal? And so then we can compare how you rated the scale to how other people are rating the scale.
And the scales are meant for that. They
Yes.
take into account, if I'm talking about a 6-year-old male,
Yep.
they are comparing him to hundreds of thousands of 6-year-old males.
Which is really important. It's developmentally set up. So like a 6-year-old male should look different than a 10-year-old female, or should look different than a 20-year-old. And these scales are set up like that to look for. So if you're going in for an assessment, you should be filling out something like this. You should be having some.
You should also have an interview. You should have
Yep.
like a formalized interview with a professional. That's typically what we do when we first meet a family. You should also have direct observations. You should see the kid in action.
Yeah. So like actually going into the school, watching them. If you get, it's hard for us to do that anymore. I would love to.
It's really hard for us. And I would say more often than not, I'm probably getting what I consider to be a direct observation in the clinic, but I'll do more of a like semi-structured questionnaire to teachers, and I'll try, if I can, to get an observation, just a narrative from a school psychologist.
I'm smiling right now because I'm thinking there are things that, as I've become a clinician and I've been doing it longer and longer, that I look for that I never wouldn't have probably even imagined to look for. And so I think at the diagnostic interview, I give way more credit now than I used to. And so, like, just for example, when you walk into my office, there's an imaginary line, like right where I'm sitting, that most children know not to cross.
Like a bubble?
What?
A bubble?
Like this bubble, there's stuff maybe back here, they might have like books or things like that. And kids with ADHD don't notice that bubble.
They're already got hands on those toys, man.
They're messing with it, yeah. And like if their toys out, they're already playing with it, And so there are things that, like in that observation, you can look for that I would early on probably never would have thought of. They might ask inappropriate questions, or they might say, "Wow, you look a lot older than the last time I saw you." Like all of that stuff, I think is important diagnostically to look for. Are they controlling their impulses?
I do little things like that in my diagnostic interview. I always ask a few questions where, once I get the kid in the rhythm and he feels comfortable answering questions, I'll like kind of spitfire a few basic facts at him to see what like what's your birthday, where do you go to school, what's your grade, that kind of thing, just to kind of like get like an observation of processing speed, just to see what I think is how fast are they moving in the classroom, kind of an idea.
So you brought up processing, but that's probably a good time.
So it is not typical that if you go to get your child evaluated for ADHD, or you get an ADHD evaluation for yourself as an adult, that someone is going to give you an IQ test. But if you're going to do an assessment, there's so much really good information to get from a IQ test. IQ tests are not the be-all, end-all, but as far as our field is concerned, they're probably the best developed tests we have, and we know the correlations. If a child with ADHD is most likely pretty low on working memory, that is probably, working memory is a skill of manipulating your short-term memory. So short-term memory, I tell you my phone number, and working memory would be like, okay, tell me my phone number backwards to me.
Right.
That's working memory. How I always think about it like, how many balls can you juggle at once? And kids with ADHD are 1-2 ball jugglers. That's all they're doing.
It's a struggle there.
Yeah.
And that's what you usually see at reverse order, or the +1. I give you numbers, add 1, and then repeat them back to me, and you'll really see. And so, but intellectually, they're fine. Like when you give them that full IQ test, and they probably show up average.
I like taking that IQ because I think, I can give such good recommendations on how you ought to educate this kid. But anymore, it's like, well, I mean, you can even have an IEP and you can even have tailored specific instruction, but, telling a teacher, hey, this kid's low on working memory, I don't know how many, if any, professionals can be pretty mindful of, I was asking that kid to juggle an extra ball that they're not ready to juggle. I just, that doesn't get built into some of the school interventions.
Because where working memory is going to show up, particularly from a parent or a teacher, is give them 3 things to do. They maybe remembered one of them, and it wasn't intentional. It wasn't on purpose. They weren't trying to not listen to you.
So a good example might be like, you got a 7th grader sitting in class, and there's, the guy next to them that they wanted to ask out, and there's a ball they got to juggle. And then 2 people are over here having a conversation. There's a ball they got to juggle. Teacher just said pop quiz. There's a ball you got to juggle. Mom and dad are getting a divorce. There's a ball you got to juggle. I mean, lunch is about to come and you're hungry. There's a ball you got to juggle. And it's like, I mean, at some point those kids drop the balls.
Right. Yeah, that makes sense. And then the other one would be processing speed is where I usually see it show up too. So in an IQ test, you're going to measure verbal abilities, some sort of like pattern recognition or looking for shapes and putting them in place.
Or even just simple addition, like real quick questions.
Yeah, but processing speed is the other one, is how quickly can you process information. And I think that, so you'll usually see delays in that. I don't know if it's that they process things slower. It's just they get off task a lot more.
Yeah.
So usually the activities you're asking them to do are things that require you to sustain attention for a couple minutes, and they don't do as well on those relative to their peers. But I really think it's not that they process things slower. They're doing it and then they're looking off and then they come back to trying to do it again.
Yeah.
And so they usually don't do as well on that as well.
I want to do something at some point where we talk about like how we see some of these IQ pieces show up with people, because I just had the random thought that anytime I'm watching a stand-up comedian, I think those comedians are so good at processing speed, reading the entire room. Something comes up, somebody's heckling them, and it's like bing bang boom, like they just at something.
Like you see a comedian go back and forth with somebody in the crowd, they are quickly processing information.
It's so fast, and it makes it come across intelligent to me.
Yeah, and I was actually just having a conversation with a friend of ours recently about how all of our attention spans have gotten worse lately. I struggle to just watch the news in the morning without like reading something on my phone at the same time, and I'm getting half of the information on both when I'm doing it. And just it feels like we're just bombarded with information anymore. And I wonder, so this is totally getting off topic compared to what we should be getting into. So it's
but good information for people to know that everybody is gonna. I mean, this is creeping in from like a cultural, societal standpoint.
Right, our attention span is getting lower as a whole,
and these diagnostic rates are.
And the diagnostic rates are going up, and you got to start questioning: is this a disorder, or is this a pandemic at this point?
So some of it, I this is just a tidbit for the audience, but when we talk about the rate at which people are getting diagnosed, there was a change in the field not too long ago too, where it used to be that our job was to figure out this like cornerstone idea, like something's going on with this kid, figure it out. Mm-hmm. Is it anxiety? Is it depression? Is it ADHD? When we were in graduate school, that was the idea. Somewhere around 5 to 10 years ago, it became, well, if they meet the criteria, just put them all down. So you'll get a lot of children on the autism spectrum that end up getting co-diagnosed comorbid issues of ADHD, and it's like, well, okay. I mean, they're showing symptoms, but I mean, is that the autism or is,
I think that's one thing we should talk about at some point, because I think we both are believers it's one or the other there. So,
well, I especially from our job is to treat, and then from a treatment perspective, that's what we're supposed to be figuring out. So, but getting off topic. Anyway, so it's not typical that you're going to get an IQ test, but if you are interested, there's some real good information to know about yourself or your kid when it comes back with that information.
Right.
The working memory processing speed is a major indicator of maybe how your kid should be approached for learning.
So, I think if you take your kid to a psychologist and they want to give your kid an IQ test, or you yourself want to know if you have ADHD and they're giving you an IQ test, I think that person knows what they're doing.
Yeah.
And because as far as psychologists go, we've got some bad measures out there, and we've got some really good ones too. And IQ is about as good of one as you can get. Been researched for a long time. They're really good about setting up those scales to be sure they're reliable and valid. And the rating scales, I feel like, are good too. Most of them,
there's a few I like better than others. There's an anxiety scale I love. It really breaks it down well. I mean, the ADHD scales are pretty straightforward. The depression scales are even worse. It's like, are you suicidal? Check yes or no. And, you get a point for yes.
Hey, do you want antidepressants? Yes or no? Yeah. And I feel like a lot of the ADHD specific ones, if I would rate those, I would have ADHD. Sometimes I feel like they're a little bit of catch everybody no matter what. So that's why I like the giving them more global ones.
Man, you talk about working memory. That is my personal weakness. I mean, it's so bad. My wife can multitask 5 different things going on at one point. I remember I had a dinner with my daughter in Florida, and I ordered like seafood, because we don't live near places to get good seafood, so we're in Florida, so I get seafood, and we had to sit outside, and so I hate sitting outside and eating because I'm just pouring sweat. So I had to manage my daughter eating her dinner. I had to deal with the heat of sitting outside. I had to manage the rest of my family that I don't see all the time, and then I had to manage cracking my food and getting like buttery fingers from crab legs and stuff. And eventually I just got crabby, and my sister looks at me like, why are you so crabby? And I'm like, I'm juggling too many balls.
Yeah.
I sent back the food, got a fish sandwich, and was like, okay, that's one less ball I need to juggle. I can tend to my daughter a whole lot better. Like, yeah, I would probably show up pretty high too.
But I think even in that story, you're bringing up a really good point, is that sometimes demands change on a kid. And when they were functioning fine beforehand, and now they're not, it actually could mean they have ADHD. It's just that their intellect was so high that they were managing it really well.
You're going to get a kid whose intellect was such a strong point that they didn't really hit a barrier. You'll have kids, I didn't have to study until I was whatever. You get to 9th grade or 10th grade or something like that. And all of a sudden you get to 11th grade and it's like, okay, calculus. And it's like, there's a lot to juggle. And all of a sudden we flexed on those, intellectual muscles, and now you're going to have to pull
things
on
have switched. Yeah. Like I think I was a decent high school football player, and then when I got to college, I sucked. The game changed. Like all of a sudden now I have to do pass coverage and I have to memorize all these different plays and things like that I didn't like in high school. I just gonna like run up and make contact with somebody.
There's grown men 4 years older than you.
Yeah, right. And it wasn't like my abilities changed. My abilities probably got better developmentally as I did. It's just now that the demands changed and my abilities where they weren't meeting those demands anymore. And that sometimes shows up with a kid with ADHD who is intellectually doing fine, and they figured out ways around things. And at a certain point, 3rd grade is usually the one I look at, but then again in high school, then again, and now their social demands have changed and it's not cutting it anymore. And so like those are the ones that are really interesting, where you see a kid who's got like a 120 IQ, 130 IQ, who like is really inattentive, has just figured out a way around it for the past 10 years.
Going back to that example I gave you about the stand-up comedians.
Oh yeah.
Sometimes I'll look at that and go, wow, their processing speed is so great. But you got to remember, if it made it to Netflix, they did that set 1,000 times. And so they've probably been heckled like that before. And so we write it off as like, wow, that's amazing processing speed. You go to football your freshman year of college, and it's like, wow, that guy's just faster. And it's like, well, okay, maybe they're faster, but they've also been running that playbook for 3 years now, and you haven't. And so we'll get into that with when we start talking interventions.
Right.
But
I think it's a good one to bring up, because ADHD is one of those ones that I feel like people are fairly certain that this is a biological one. This has to do with your frontal lobe. This has to do with your executive functioning. But sometimes it's not. Sometimes there's environmental things going on too.
Yeah.
It's not. There's the environment's not really set up for, if your kid is doing their homework with their phone sitting right next to them in their room with their computer and their.
If
Xbox.
your kid is doing that right now, please just go take the phone away from them while they're doing the homework.
Stop.
Dear God, please stop.
Right, and so that's why we're having cultural ADHD as part of this. Is I'm trying to manage all of this stuff at the same time. Like I'm so happy we did elementary school and we did it, because it'd be so much harder now.
Yeah.
And so it can be environmental based too.
I think that is our job diagnostically. So when we talk about diagnosing ADHD, it shouldn't just be get these ratings and look at the ratings and they hit a level of clinical significance, so I guess we're going to diagnose them ADHD. I mean, we have to look at what's the difference between hyperactivity and, well, he's 5 and this kid comes from an environment where they've never been asked to sit still in the same room.
Right.
Same chair.
Yeah.
So we're supposed to look at that and figure out that context and go, yeah, this kid is indeed hyperactive, but there might be something else going on there.
I think I really want to be sure we say this is the majority of the time they shouldn't have ADHD. The majority of the time,
it's like what, a 5% occurrence rate in the population.
And they keep pushing that up. I want to say DSM says 7 to 10 now. It just doesn't make sense, that it should. I think when we get into our evolutionary explanations for ADHD, we've got some pretty good ideas on why it actually should happen.
Yeah.
I have no problem with it. It is a disorder and that it does happen. It's just. It shouldn't happen as often as is being diagnosed.
Right.
And so for the most part, when you do all this kind of formalized assessment that you're discussing, the most of the time you should find nothing, which is really nice about those rating scales, is that you can be, slightly above average, but it doesn't mean it's clinically significant. maybe you struggle with working memory, but it's not that bad. Maybe you struggle with organization, but you're okay. Maybe you struggle with planning and problem solving, but really you're just slightly worse than average.
And we were talking about how many balls you can juggle. I mean, if you got a family with like 5, 6, 7 red flags, who wouldn't look inattentive?
Right. Yeah. And so, like, why don't we fix that stuff first? Because what are the side effects of fixing some of that stuff? Nothing. Things get better. Like,
I hate to spoil it for everybody because we just living through a pandemic. But let me tell you, if you're looking at your kid over the past year thinking like, man, they look hyperactive, it's everybody has gotten cabin fever and we've been stuck in our homes more with people. Sports shut down, which we'll get into that and how that impacts ADHD. But I mean, individuals can only handle so much complexity, and for a kid, it's like, I mentioned before with like those juggling balls, and there's somebody when they ask out on a date, there's parents getting divorced. It's like, yeah, everybody is gonna crack. I mean, they're gonna look inattentive. I mean, that's just how it looks.
I did during the pandemic, and I'm pretty attentive. Like, I'm probably obsessive on certain things, and I think it's just gonna happen. And so that's situational stuff that really we should look at the situation and try to fix the situation.
I don't want to get out on too skinny of a branch here, but I will say, there's good evidence. We talked about the brain evidence and the delay in that frontal lobe, and I mean, I'm sure you've had an experience just like I have where you get a young kid that walks in the room and I mean, in 5 seconds, you're like, oh yeah.
So this is what I want to get out to. Hopefully parents are watching this. This is an interesting, like maybe anecdotal, and I'm curious if you've noticed it too. And I think you have, because I want to say we've talked about this before. But there's this interesting thing that I notice when I have parents bring a kid in who think kid has ADHD. I rarely see it. When I have a parent who comes in and says, yeah, we're just kind of worried. Like we don't really know what's going on. We just want him to see somebody or her to see somebody. And him is probably more likely, and we can talk about that too. That's the one who really has ADHD. It's the parent who comes in and is like, we don't know. And then I'm like, whoa, like your kid's all over the place here. And like, it's just a really interesting phenomenon that I've noticed is the ones who come in and are actually like thinking that the kid has ADHD, where I'm usually like, that's a little more than average, but it's not really that big a deal, versus the ones who are coming in just kind of like, we want to see if Johnny wants to talk to you a little bit. And that kid is the one I'm having to be like, yeah, we should probably do an assessment here. Have you noticed a similar?
I've noticed a few anecdotal things that I feel like it's probably irresponsible for me to go on, for some of them. Yeah. For this one though, I mean, I have the experience all the time where if I have a physician saying, I need you to do an evaluation on this kid, and the family's like, I guess, okay. Yeah. It's like, okay, yeah, no, this is going to be the kid that comes in with just all kinds of high scores.
So I don't know what that is, where the parent who doesn't expect it is the one where I see it more. I don't know.
Well, I mean, we're talking about learned behaviors. We're talking about, has this kid ever been asked to sit still? And, a lot
of families, could be something cultural too. Yeah.
Right.
Yeah. It's just something I've noticed over the past 10 years. So, I said it's probably a boy. You want to talk about that a little bit?
Well, yeah, I guess let's talk about.
I mean, I think we're getting into diagnosis, and we didn't mention that boys are way more likely. To be
way more likely, yeah.
I think we'd be missing a little part of that. Just while we're on it, it seems to me, and I want to say there is some research for this. I probably should find the reference on this. Is that boys are more likely to be diagnosed. When girls are diagnosed, it's pretty stinking bad, though.
Yeah,
like it comes off as very inattentive, very hyperactive. So.
I mean, there's a lot of things going on with those differences. Boys are typically higher in, like sensation seeking. Boys are typically higher in, no, you don't think so?
No. I just, in my mind, boys will be boys. Just show up right in my mind. And it tends to be that we kind of downplay it too earlier on, and we maybe ignore it too. So the sensation thing. No. Right. I totally agree with what you're saying. I just was thinking of like why that sometimes gets, let go for a while. So
they're going to be more likely to engage in rough play. Mm-hmm. They're more likely to be externalizing versus internalizing.
So external, I'll just explain that for you. Yeah. So externalizing is the behavior problems you see. So like defiance, aggression, and things like that. Internalizing is the behavior problems you don't see. So the kid experiences them, they're just harder to see. Anxiety, depression.
Right.
And so boys are generally going to be higher on the externalizing stuff. Girls tend to be more on the internalizing stuff. It doesn't mean that it doesn't cross. sexes. It doesn't
Right.
go. It occurs across sexes. Just if we're looking at just statistics, that's the way it happens.
There are some mental health diagnoses that are heavily weighted in categories for females, but I'm anxious to actually hear if you know any other research about this other than what I know. But what I was educated on in graduate school was that the most likely situation is that something to do with ADHD and something to do with things like autism, which is also highly more prevalent in males than females, has something to do with the X chromosome, because boys only have one. They have an XY, girls have
Right.
an XX. And so girls typically have, if you look like on a microscopic scale, the X is like towering over the Y. There's so
Right.
much more information on it. And so girls having two X chromosomes have more to compensate to make up for where deficits might be. Whereas the boys, it's whatever X you got is going to be what it is. So like you said, when a girl comes through with ADHD or autism, it's typically
Bad.
real pervasive, because
Right.
that means both chromosomes are rocking the same thing.
Right, and we probably should have a geneticist. Because my understanding of that was that if it is a recessive gene, then the boy is more likely to have it. The girl would be more likely not to, because they have the other allele there
Yeah.
on the other X that would counter out the recessive gene. If ADHD or anxiety or something like, or autism, I would probably ADHD, autism. Those would be the major things. So anything that's genetically based, the Y chromosome makes you susceptible for having that, because if it's a recessive gene, you just aren't going to have the other thing there, to the other allele to knock it out.
And we know there's some sort of genetic component to mental health. I mean,
Yep.
like there's tests on identical twins with
Yeah.
schizophrenia, and that's like the highest, comparison correlation. And then there's, I know that if a parent has a history of depression, that's I think it's like 25 times more likely that a kid is going to have a mood disorder or something like that. So there's genetic components to it. It's just this is one that is not totally fleshed out yet.
No.
We don't totally know what that is yet.
Wow.
Which is odd. You'd think that maybe it's just I wouldn't be interested. I'd be interested in going and digging through the research to see if I find something new. But with them mapping out these genomes, you'd think they'd come up with something where it's like, oh, yep, they hit on blank, blank, and blank, and that's
Yeah, just the more it seems like it's funny. I remember in elementary school when they were doing the Human Genome Project, and I think I learned like in my 30s, like they did that already, and I was like, oh, they're done with that. Like, I thought we were still doing
I didn't
that.
get any notification on my phone
because they did it and they found out, oh, like just mapping it out doesn't tell us a whole lot, because there's so much more going on. Interaction between your genes and your environment, and how like the environment can actually so what is it? The study of epigenetics, like all came out after, like the whole study of epigenetics came out after they realized, well, basically the human genome, mapping that out didn't really help us understand it, because genetics, not only your genetics affect your environment, and your environment affects your genetics, and your environment affects the genetics of your child, and that affects their environment. So it just was way more complex.
And even still today, I would say the public's understanding of environment is real limited. They think that's like, I think it would be a normal misconception that a family might say, well, you had two kids raised in the same house, that's the same environment. It's like, that's not at all. I mean, you start diverting fast when you come down to like, what's the environmental influence on somebody's, genetic composition.
Yeah, totally. Yeah.
I don't know if you feel this way. Let's find out. I feel like ADHD is very similar to the takes we've already discussed on anxiety and depression. The part of it is just because it got named.
Yeah, yeah. I like finding like universal themes. Yeah, that makes sense. And it got named. I think part of it has got named, and then part of it would be environmental shifts, in expectations, but not
That's right.
not in the same way I was talking about earlier. So in a different way. So environmental shifts and expectations, like, you were in third grade, it was different than in second grade. I'm thinking environmental shifts as in going back to the hunter and gatherer stuff. And so that the requirements now for a 10-year-old are a little different than they were for the cave person 10-year-old. So
Different on all kinds of levels
Yeah.
too. I mean, we're talking like different expectations for behavior, morals, ethics, like all those factors come together. And you and I both subscribe to functional contextualism, which is the idea that basic functional contextualism would be, what finger is this?
Pointer.
What direction is this?
Up.
What number is this?
1.
Nothing changes about the finger, but as soon as I cue you into a different context, your experience of me
The whole
holding up
meaning
my index
changes.
finger is completely different. So I just look at ADHD and I think currently today, if you've got a kid in the school system, the way our school system is set up, I mean, the likelihood that you are going to call a kid hyperactive is pretty high. Whereas 500 years ago, we're all plowing fields and hunting. I mean, the hyperactive kid was your number one draft pick. That's who you wanted.
Yeah. Let's get Billy out there. He'll have this thing done in a week.
Right. Exactly.
Yeah, no, it makes sense, yeah, too.
Just the idea that even, I said 500 years ago, I mean, even 50 years ago.
Yeah.
The idea of, little Timmy left for the day and didn't come back until 9 hours later, and he got into all kinds of ridiculousness. He ate too many crab apples, swam in the swimming hole, bullied somebody, helped somebody unload their truck, and then they came home. It's like, that is not the context we are living under anymore. And if that had happened for a kid back then, we would have all said, like, pretty normal day. And now it would have been like, you helped who do what? You don't know that person. You talked to a kid you didn't know and you were mean to him? What are you talking about? I sent you away and you came back 9 hours later. What are you talking about? Like, that is not how we view kids today. Morally and ethically, we would look at a kid and think morally, you should sit down and focus and listen. And that's what makes you a good moral learner and student. And I mean, if you right today went into high schools and told them, okay, we're introducing dirt biking 101. Let's see how everybody does. That current valedictorian's in for a bad, rude awakening.
Right. Or in elementary school, we're doing tree climbing today. You know, like half of you have to sit down and read the book on tree climbing, and then other ones get to go out and climb the trees. We know who's going to do better and who's actually going to be better in the end. And it's I was just thinking as you were saying that I remember the thing that I never thought of is that every species seems to have this kind of time in their life, their adolescent phase, where they're more impulsive. They don't make good decisions. They don't think about the negative things that could happen. They way overplay the positive things that could happen. Like even in rats, you see it in rats too. Is like the old rats tend to be pretty careful. Young rats tend to be pretty careful.
Speaking of which, symptoms of ADHD are supposed to dissipate significantly after age 30.
Yes, it makes sense. And so every species seems to have this kind of adolescent time where it was advantageous for us to be impulsive, to be a little bit hypersexualized, to make bad decisions.
Helps the species going if you've got 9 guys who are like, I don't know, man, it looks too cold out there. And one's like, I've got to go find somebody, so I'll see you guys later.
Right, yeah. And so I think it seems to be themes for us as evolution. And then a lot of this is like normal behavior. Mm-hmm. And it does not mean that they have a disorder. I think we've talked a lot here about the things to look for if they actually do have a disorder, and maybe consider that some of this is just the environment changed. The human brain's trying to catch up, and we haven't caught up yet. And all species have this adolescent phase where they're a little more impulsive. They don't think things through sometimes, and it'll get better. It's.
As you said it reminded me, we never even said earlier, part of the diagnostic criteria is that it happens across different settings. Like this should be, if your kid's hyperactive, it should be hyperactive at home. Your child should be hyperactive at school, hyperactive in my office, hyperactive at sports. And it would be really normal if as a parent you came in and you said, I'm telling you, especially after a year of a pandemic, my kid is really, really hyperactive. And then they go to school and they don't present hyperactive in that setting. A little bit of hyperactivity would be normal, and depends on the structure, depends on the way that environment's set up, the rules, the expectations, the culture in that environment.
Yep. Yeah. It should occur across setting. If not, it's not a disorder. It's setting-specific behavior.
Right.
There's one thing to whisper when you're in the library, but if you whisper everywhere you go, you might have an anxiety disorder.
That's like, I'm stealing that at some point. Yeah, that's good.
No, it's just, context for behavior. And so you like you brought up with the finger, you slightly alter the context. The behavior is totally different, so you don't walk into a bank and lay down on the floor. That'd be really weird. But if you walk into a bank and somebody comes in with a mask and says, everybody get down on the floor, like, you better get down on the floor. Because once you change the context, and so some of these kids just aren't good at picking up on those things, and they're struggling across contexts, and they're not, but it just wouldn't be a disorder if it's just in the one area.
Let's hit a solution though from like diagnostics. A solution I feel would be one, if you know a kid and you look at that child and you think man, they're hyperactive,
Yeah.
and man, they don't focus. Just cue yourself in as an adult, especially if you're an adult that's going to have a role with that kid. 500 years ago, your experience of that kid would be completely different. It is, we have a system, we have a public education system, we
Right.
funnel them through that system. They are hyperactive in that system. They're hyperactive in our culture. They're hyperactive in our current settings. That doesn't necessarily mean to be the case 500 years ago.
Yeah, that's fair. So like that would alter at least your perception of it. I would say as a parent or even as an adult who thinks they might be struggling with attention, I would look at what are the things that I'm doing that might make it so I am struggling with sustaining attention. You know, are there things that I can can I alter the hygiene of studying, you know, or can I alter something in the setting to see if maybe that changes my attention, you know? So as a parent, if you're giving your kids tons of stimuli at the same time, you're just promoting those symptoms. You know, like if your kid has talked you into like, well, I do better when I do my math when I'm listening to music, don't get talked into that. Before you've kind of come to the conclusion that my kid has ADHD or that I myself have ADHD, let's look at the environment. Is there any way that I can limit some of the stimuli and maybe like focus better and try to mess with that stuff first?
And our profession is supposed to help you with that.
That's like a good psychologist should be doing that.
And I think I would say the real solution is, a lot of times as a parent, you may have had a situation where if you took your kid to a psychiatrist or a physician and you told them, my kid is hyperactive and inattentive, they may just offer you a prescription right there. Right. But we would suggest do your due diligence. We're not big assessors. We're not huge on assessment. We don't love that part. I don't love it as far as practice. I don't love it as far as like a description of a kid. I don't like pigeonholing kids, but do your due diligence. Part of that is working with a provider. Part of that is going through interviews. Part of that is potentially doing an assessment. It shouldn't just be, man, they're hyperactive. Well, guess it's ADHD.
Yeah. All right. That was pretty long.
Yeah, we went way longer than I thought we were going to.
Yeah.
So the next episode, we're following up. We're going to do more on ADHD. And thanks for listening. See you next episode. Don't forget to click like and subscribe. You can follow us on our Instagram at DMB Psychology for updates and to submit any comments or questions. You can also find us on our website, domorebetter.buzzsprout.com, where we have info on all episodes as well as our donations and merchandise links if you'd like to support the podcast. You can search for us on YouTube and all major podcast platforms under Do More Better.